Hello, my name is Ann Sarah Pabanga, and I live in Charleston, South Carolina. I have two daughters, and my younger daughter had a combined kidney and liver transplant 15 years ago, this June. She's now 16 years old. Welcome to our session entitled Cutting Edge Research and Advancements. We are sorry for the last minute change, but Dr. Carlos Esquivel cannot join us today. But we're very excited to hear from Dr. Paul Grimm on his presentation entitled Kidney Transplants Without Being Dependent on Immunosuppression, Early Success, and Lots of Promise. Dr. Grimm, please forgive me for condensing your very extensive bio. Dr. Grimm is professor of pediatrics and the medical director of the Stanford Children's Health Pediatric Kidney Transplant Program at Stanford University School of Medicine. He's originally from Saskatchewan, Canada, with training in Halifax and Manitoba and the University of California, Los Angeles. He has been at Stanford since 2007. His previous research was on transplant immunology and renal pathology and image analysis. His focus is now clinical pediatric kidney transplantation, especially the problem of infants, highly sensitized recipients, multi-organ transplants, cystinosis, and patients with unusual transplant problems. He has published approximately 90 articles in scientific journals. He directs the Stanford Pediatric Nephrology Fellowship Program, and he shares his home with his wife, his 3 children, and a miniature poodle. Thank you so much for being here, Dr. Grimm. Without further ado, I'd like to turn it over to you.
Thank you very much, Ansara, for that great presentation, and my dog will be happy that he was remembered. So I wanted to talk with you about some of the research that we are doing to try and go to the next level of organ transplantation at Stanford. And although this is really kidney focused, much of what I'm going to talk about is applicable to people living with other organ transplants, such as liver, and especially living donor liver, and potentially even heart and things like that. So the year was 1954. One of these 2 twins has kidney failure from membranoproliferative glomerulonephritis. They're talking to Dr. Kolf, who was one of the developers of the dialysis machine. And this big thing, which looks like a robot or a dishwasher, is a dialyzer. And they're talking to this young man about going on dialysis. Well, he had an advantage, and that was he had an identical twin. And so after much discussion, much prayer, and much reflection, it was decided that the identical twin would give one of his kidneys to his twin who was about to go on dialysis and probably die. So this is the picture of the OR in Boston. And it looks like any regular OR from the 50s. There's a door here. And this operation, the first kidney transplant that worked, is memorialized in the Library of Medicine. And here the door is open, and you see the donor operation here with the donor on the table, and then they just walk the kidney across the hallway to the recipient. Now, this looks like any old regular operation, but it's good to remember that when this was going on, there was a riot happening outside the hospital. Members of the religious right thought that this was against God and this was evil. We were going to take a healthy human being and mutilate that person's body, taking out kidney in some crazy idea to keep someone alive who clearly God wanted to die. There was a legal attempt to block it. There was lawsuits, and there was a riot. The cars were blocked. There were the police, but the surgical team went ahead and successfully did the transplant. And it was successful, and no immunosuppression was needed because it was identical twins. And the person who received the transplant lived for another 7 years. Ultimately, he passed away because of recurrent disease. His donor, who died in his 70s, was very quiet, but he gave an interview where he said, donating my kidney to my identical twin and giving him 7 more years of life was the most important thing that he'd ever done. Fast forward to today. Most people don't have an identical twin, but we have developed over time the understanding of the immune system enough to suppress the immune system to block the rejection response. And every few years we learn more and are getting better. And the intent of this slide is to show the outcome if you get a deceased donor kidney. Now, the orange line goes out to 10 years post-transplant. This is graft survival. And this pink line is people who got transplanted in 2014 to 2017. And you see every few years, our results are getting better as we learn more about the immune system and learn more about how to do these transplants. And that translates to patients having better quality of life. The other thing I wanted to point out was the difference between deceased donor and living donor. So living donor kidneys clearly last longer and work better than deceased donor kidneys. And that has continued over the years, even as we get better understanding. So when I'm counseling a family who have come for a potential kidney transplant evaluation, the numbers I quote is the average kidney from a deceased donor, someone who signed their organ donor card and had an untimely death, was hit by a bus. The average kidney lasts about 12 years. Now, if you get a living donor kidney, that average kidney lasts, in our current understanding, 19 years. So there's a difference of about 7 years. And what's interesting is that difference between deceased donors and living donors has been expanding as time has gone on. Kidneys that were transplanted in the late 90s had a difference of about 4 years. So living donors lasted on average 4 years longer. But over time, it's gone up to 4.1, 4.3, 5.2, and now 7.5 years is the difference. So we always try and get a living donor if we can, because that first kidney tends to be the best one. However, kidneys don't last forever. And the other information we tell families is if you have a 7-year-old, this is not their only kidney transplant. This is the first of at least one or two more. Because the reality is a deceased donor kidney lasts on average 14 years, living donor lasts on average 19. You want your kid to be old enough to get Social Security, to see their grandchildren. So they're going to need more than one or two kidneys. Well, why is that? Well, one of the hard things is we are dependent on immunosuppression. We're dependent on technology for the lifetime of that transplant. And this is the risk of graft failure per 100 patients, and this is age. So if you're a 3 or 4-year-old living with a kidney transplant, your risk of graft failure is like one graft loss per 100. That's because mom and dad look after your immune system, your medications. If you're age 37 or 38, your risk of graft failure is about 2 grafts per 100 per year. But if you're 17 or 18, that shoots up because teenagers' brains are developing and they can't remember. There's non-adherence, all the hormones going on. And so the reality is this increased risk of graft failure is 1 year, then the next year, then the next year. So there's only a 50-50 chance that a teenager who has a transplant will keep their kidney through the teenage years. This is adherence, and this is purely because teenagers are teenagers. But there's other issues. We know that living with a kidney transplant, there's drug toxicity. And this sort of cartoonish picture of the problems of prednisone, obesity, anger, stria, we all know this is a very real issue. But other drug toxicity is the fact that tacrolimus and cyclosporin damage kidneys. They are toxic to kidneys. And so the drug which is keeping the kidney from being rejected is also chipping away at the kidney. We have issues with viruses. Epstein-Barr virus, CMV, and BK virus all can damage the kidney. And because your immune system is suppressed, those viruses can get a toehold and really start doing a number on your kidney. New onset diabetes. So one of the sad things about tacrolimus, which is a wonderful immunosuppression, is it causes new onset diabetes in up to 35% of patients. And the highest risk group are people who have a heritage from African American or Hispanic, who are obese, who might have a history of hepatitis C, were pre-diabetic before the transplant, need a high steroid dose, or have a disease called cystinosis. All of these people are at much higher risk of developing diabetes after transplant. Okay, you got insulin, right? Big deal? It is a big deal. This is data from the United States looking at the impact of diabetes on young kidney transplant recipients. This is patient survival. So if you go out 15 years from the transplant, the difference in your likelihood to survive if you're a young person between not being diabetic and being diabetic is 20% risk of passing away. So diabetes is a huge factor in quality of care and long-term outcome, and it is triggered by the drug tacrolimus. This paper really caused me to pause. When I'm counseling families about immunosuppression risks, we talk about the risks of certain kinds of cancer. Well, at the Hospital for Sick Children in Toronto, they did a study, and because it's a single payer system, they can follow the children who got an organ transplant for 50 years. What they showed was if you are a child who gets a solid organ transplant in Ontario, Canada, which has a high quality system, and that child is still alive 20 years later, the chance that they have had a severe life threatening, life changing cancer is 20% per kid. About 5 or 6% solid cancers like bone cancer, brain cancer, and about 15% PTLD, post transplant lymphomas. That adds up to 20%. And in children who are alive 30% after their transplant, over 35% have had a major cancer. And why is that? It's because the immunosuppressive medications that prevent rejection that we desperately need also reduce the body's defenses against cancer and against infection. Because the immunological processes that cause rejection are exactly the same cells that protect you from infection and cancer. So there's a yang and yin. I can tell a patient, I can give you enough drugs to guarantee you will never reject your kidney. But that leaves your immune system so suppressed that you're a sitting duck for viruses and cancer. And that's the fundamental problem, that there's a balance. And in everybody, the balance is different. So how do we get around this? And this is where the research comes in. So this picture here is a chimera. Back in the day, the Greeks believed that there were animals that were part lion, part goat, part snake. Other cartoons might show them with horses' legs. So these are an animal made up of multiple other animals, and that's called a chimera. Well, the immune system can be chimeric. So the hope is that we can take the immune system of the donor and mix it with the immune system of the recipient and have the two immune systems coexist. And that might allow us to do organ transplants without drugs. And this is where we talk about stem cells. What's a stem cell? There's a very small number of stem cells in your body, about 10,000, and they are lazy. They only divide about once a year. Normally, they just sort of sit there and they hide. But when they do divide, they generate all of the cells in your bloodstream. The megakaryocytes that protect you, that make platelets that protect you from clotting, the basophils, neutrophils, eosinophils that protect you from bacteria, funguses, and viruses, monocytes, and lymphocytes that protect you from cancer and viruses, all come from the stem cells. So when we talk about stem cell transplants, we're talking about putting a few stem cells in the body and they will recapitulate the bloodstream and the immune system. So the research is very interested in mixed chimerism versus complete chimerism. So mixed chimerism is where you set up the patient so they have a little bit of the immune system of the donor and some of their own. The benefit of that is that balance prevents them from getting a complication of a stem cell transplant called graft versus host disease and a low risk of infection. But the downside of mixed chimerism is we haven't figured it out yet. Now, complete chimerism is when you do a stem cell transplant and you completely remove all of the donors, all of the recipient immune system, and the donor cells come in and take over the immune system. So the person who gets the stem cell transplant, their circulating blood is all come from the donor. So there's a high risk of graft versus host disease and infection, but a very low risk of recurrent disease. So there's different ways to do stem cell transplants, and there's lots of research going on. One example is the one study. The one study is 8 different centers in Europe and in the USA. And this is just one example. There's other studies going on at Northwestern, for example, where they're trying to figure out how much do you suppress the immune system? How many stem cells do you give? What kind of cells do you give? And so this is an example of various protocols. No one in the one study has been successfully given a kidney transplant or other organ transplant without immunosuppression, but they're working on it. Now at Stanford, on the adult side, my colleagues on the adult side have been working on tolerance for more than 20 years. And what they do is they'll do a kidney transplant from a donor, a living donor, and they've got it worked out pretty well if you have an identical donor. So if you have a brother or a sister who's identical, they do the kidney transplant, and then they give them total lymphoid irradiation. And then after a period of time, they give them stem cells from that donor, which can be drawn from the blood. And then they use various immunosuppressive drugs and slowly taper them. And they've gotten most of their patients off drugs completely. Well, not everybody has a sister or brother who's an identical match. And for children who I look after, very few of them have an old enough sister or brother who can ethically give a kidney. So when you look at one haplotype match, which is like from a parent to a kid, this is my most common living donor kidney transplant. The Stanford protocol hasn't worked out yet. A few of them are able to get down to one medicine, but it doesn't last. So the Stanford protocol, they're working on it, but for the living donor kidney transplant that I'm interested in, it doesn't work. And the problem is the immune system is complicated. And so people have an idea of how can we mix the cells. It's a simple idea, but it hasn't been gotten right yet. The immune system is very complicated, and it takes a lot of research to figure out how to get to your target. So we've taken a different approach for children at Stanford. We've said, why not do complete chimerism? Why not completely switch the immune system of the child to become the immune system of mom or dad, and then we can do the kidney transplant without any immune system at all. There is the fear of graft versus host disease because this is a full-on stem cell transplant, but the research has made it very safe. See, graft versus host disease is caused by cells that are not stem cells. So the researchers then said, why not just give stem cells? So here we have a donor, and we give them a medication that causes all the cells to circulate in the bloodstream, including stem cells, and we draw them with an IV in a special machine. We can then take these cells and separate out just the stem cells. And it turned out when you transplant someone with just lonely stem cells, they don't do very well. They need a village. They don't grow well alone. They often get rejected, and the patient gets infections. So that's a non-starter. So what are the cells from the donor that actually cause the problem? It turns out there's something called gamma delta T cells. Turns out they protect the child against infection and they support the new stem cells by producing growth factors. That's good. There are NK cells. They protect against infection, different kinds of infection, and they also support the new stem cells. That's good. Alpha beta T cells. Turns out these are the guys that cause graft versus host disease. We don't want them. Stem cells, of course, we need the stem cells. And B cells. Now, B cells carry Epstein-Barr virus in their genome, and they also are the main culprit for post-transplant lymphoproliferative disease. We don't want those. So it turns out if you engineer the cells you take from mom or dad, you can get this done. So in our protocol, the donor mom or dad gets their blood drawn, and we pull out the nasty cells, the alpha beta T cells and the B cells, and we give the child also a drug called rituximab to kill any leftover B cells. So when we infuse the cells into the recipient, we are just infusing the gamma delta T cells and the NK cells and the stem cells that are good guys. And this has already been used in other genetic disease patients. In fact, this protocol originated in Rome at the Hospital of the Baby Jesus in Rome. And one of my colleagues, Dr. Bertena, is the chief of stem cell transplant at Stanford. So she came over to Stanford and she has brought this technology and developed it. And so now more than 70 patients have gotten stem cell transplants for various conditions that are not cancer, like metabolic disease, immune deficiency, bone marrow failure, etc. And very low rates of infection or graft failure or the need for retransplant and very low rates of death. So this is much safer as a stem cell transplant. So about 4 years ago, we had this disease called Schimke's immunoosseous dysplasia. And this is a childhood disease of a single gene. And that gene is important at DNA repair. And it's rare. It's 1 in a million or 1 in 3 million births. But for the children that have it, it's a hideous disease. It's a progressive multisystem disorder. They're very short. See how short the chest is here? Because the T cell, the vertebrae are all squashed. They have a T cell deficiency, so they can't fight infection properly. They develop kidney failure before the age of 10. And if they somehow survive through dialysis or transplant, they develop strokes and death by their 20s. Now, for the kids who have had a kidney transplant the standard way, the outcomes have been really poor. You see, if you don't immunosuppress them because they have a T cell deficiency, they'll reject. So you need some immunosuppression. But even the slightest amount of immunosuppression makes them at risk for infection. And then if you get the right balance, they get cancer. And I've looked after these children who have had cancer. And some of them will get graft versus host disease from the kidney because there are cells of the immune system in the kidney, like little lymph nodes, that will get into the patient. And that's enough to cause these children to pass away. So it's a really difficult disease. So we thought maybe this would be a great disease to do our stem cell transplant program on because we could help with various parts of the bloodstream and their immune system dysfunction. So if we could do a stem cell transplant from the mom or dad, once the stem cells are fully recovered and engrafted, we can take a kidney from that mom or dad, stick it in the child. So this is the same donor that gave the stem cells. No immunosuppressive drugs would be needed because the immune system is from the kidney. When you put the kidney in, the immune system says, hey, friend, how are you doing? So no drugs theoretically would be needed. So no risk of cancer, no risk of sepsis, no risk of rejection, and no risk of PTLD or cancer. Doesn't matter if they don't adhere because they don't have to take anything when they become nasty teenagers. And no countdown to the next transplant. Because the countdown to the next kidney happens because of drug toxicity. We're not using drugs. Little bits of rejection, chewing away at the transplant, no rejection, no non-adherence. So potentially this kidney could be one and done. It could last forever. So why not do it? Well, the conditioning. The conditioning is the term we use to make the space in the marrow. You can't just throw in some stem cells if there's no place for them to go. So we need to use a therapy to kill that child's stem cells and to clean out the marrow so that there's room. And there's all sorts of different conditioning for different disease processes that the stem cell doctors have learned. You know, if you have cancer, there's one kind of conditioning. If you have bone marrow failure, there's a difference. If you have a genetic disease, it's different. So we're trying to find what's the least amount of conditioning that these kids can tolerate and for us to still be able to do the transplant. So our reduced intensity conditioning is, it's I've been impressed with this, our stem cell doctors. It's almost like being a cook. It's almost like tasting the patient. Needs a little more melphalan or maybe a little bit too much cyclophosphamide. But they use low doses of these drugs and a tiny bit of total body radiation, a single dose of 200 centigrades. To put that in perspective, if you're doing a stem cell transplant for cancer, the dose is 5,000. So 200 is like barely a whiff. But the patients are in hospital about 2 weeks to get ready for the stem cell transplant. Different drugs are given on different days. And then on day 0, they get their stem cell transplant. And the stem cell transplant is really a letdown because it's just a little syringe of pinkish yellow stuff that gets squirted in and they're done. Like no fanfare, nothing. It just seems so like you're expecting this big thing and it's done. After the stem cell transplant, you wait for the patient to recover and then you do the kidney transplant. Now, for the first 3 kids that we did with Shimkes, which are in a paper that's coming out in May, they engrafted by day 15. So it took 2 weeks for the stem cells to grow up white cells and platelets to start protecting the patients from infection. One of the kids had mild acute graft versus host disease, which was treated with a week of prednisone, fully recovered. In these 3 kids, we then did a kidney transplant from the stem cell donor anywhere from 5 to 10 months after the stem cell transplant was done. And we waited that long to give them a chance to fully recover and be healthy so that they'd be able to bounce back from the rigors of surgery really quickly. And we did put them on immunosuppressive drugs for a month because we were chicken. And we theoretically thought, well, maybe there's a risk for graft versus host disease. Maybe we thought there was a potential for ischemia reperfusion, but we also just felt more comfortable with doing this experiment. And now 21 months, 22 months, and 33 months, almost a year and a half later, these kids have a perfect GFR. They're on no immunosuppression. They've had no complications. They're 100% chimeric, which means their mother or father's immune system is circulating in their veins and is persistent. And when you do the mixed lymphocyte culture, what it shows is that the immune system is totally accepting of the child and the kidney. But if you expose the immune system in the test tube to anybody else's immune system or a virus or a bacteria, there's normal responses. So these kids are hopefully cured. We have permission to use their pictures. So this guy gave his kidney and bone marrow to his daughter. This woman gave her bone marrow and kidney to her son. And this was our third Schimke's patient and they're all doing really well. Okay, Schimke's, very rare disease. What does that mean to your rank and file children? Well, this was the first time anywhere that a pediatric stem cell transplant was performed with the express purpose of immunosuppressing after an organ transplant. And we could get away with it because the children had such a nasty genetic disease that the risks outweighed the benefits theoretically, and we've proved it. Now, we need long-term follow-up. There's no doubt that we need to follow these kids for years. But we feel confident enough that we've started expanding the indications to other diseases like the genetic disease cystinosis. And one of my most terrifying diseases is recurrent focal segmental glomerulosclerosis, which FSGS is one of the common causes of kidney failure in childhood and adults. And when it comes back in the transplant, it's very, very difficult to treat. So where are we now? We've done 6 stem cell transplants at Stanford. The fourth is a Schimke's. He's had his stem cell transplant and he's recovering. He's been tough because he's been on hemodialysis for many years before the transplant. And he also has congenital heart disease. So we have such a multidisciplinary team involved. You know, the stem cell docs, the heart docs, the kidney docs, infectious disease people, but he's getting ready. He's recovering from his stem cell transplant. We've done a patient who had a previous graft loss from focal segmental glomerulosclerosis, and this hasn't been published yet, but we're putting this together because this is important. So this is a person who had FSGS, so nephrotic syndrome, prednisone didn't work, standard drugs didn't work, started at about age 3, and when he was 9, he was in kidney failure. His mom courageously gave him her kidney, and that kidney was destroyed by FSGS in 3 months. So within 3 months, he was back on dialysis. He spent the next 10 years of his life on dialysis because no program in their right mind would transplant him again, because they knew that the risk of the kidney, the next kidney getting FSGS was really, really, really high, and no one would take the chance. And he had gotten all the standard medications and immunosuppressive therapy, and the kidney was lost in 3 months. But we felt it was worth the risk because of our preliminary successes with the other patients. So we accepted him to our program at age 19. We did the stem cell transplant, and he had a very severe case of graft versus host disease. Our stem cell transplant doctors, with this protocol, which is supposed to be wonderful, they'd never seen anything like it. And we think it's because his immune system was so activated by the underlying disease and all the immunosuppression that he'd gotten for more than 15 years of his life. But we got him through the graft versus host disease. He's fully recovered. He has no side effects of graft versus host disease. He got his kidney transplant from his father who donated the stem cells. And now, 80 days after the transplant, he's cured. He's on no immunosuppressive medication, not even a hint of recurrence of FSGS. So we think we've cured him. And now he's just recovering from all the complications of 10 years of dialysis, but he's even back on the tennis court. So we are just delighted at this one. We have one patient with cystinosis, and cystinosis is another genetic disease. It's a lysosomal storage disease where the treatment is very, very difficult. He's recovering from his stem cell transplant, and he's off his cystinosis medication. He's not yet on dialysis, but he's close. And so we are planning to go ahead with the kidney transplant from his parent in June, so in 2 months' time. So in summary, we have now 6 patients, 4 completed kidney transplants, 2 more that are going to get their kidney transplants. And this protocol looks like in selected patients, it might be really useful. But there's a caveat. The immune system after a stem cell transplant takes years to become completely normal. The white blood cells that fight bacteria come back within a few weeks. The B cells that make antibodies come back within a few months. But the T cells that really protect you against funguses and weird, strange protozoa, it takes them years. So for years, these patients will be on prophylactic antibiotics, and we have to keep an eye on them just in case. But it looks pretty promising. The future. If this protocol proves to be safe, we are looking to extend it to other diseases which may come back in the transplanted kidney, like IgA nephropathy or lupus. Because if you do a stem cell transplant, you may reboot the immune system completely, and the patient may not have these diseases afterwards. We're also preparing to start using this on otherwise normal kidney transplant children and teens who have a high risk of non-adherence. Maybe they come from a very chaotic family. Maybe they're just crazy teenagers. So we're thinking about that as a group. But what we're really hoping for is to be able to advance this to areas of the world which are resource limited. You know, there are many parts of the world, like in Africa and Southeast Asia, if a child in the family has kidney failure, they just have to die because it's too expensive to pay for dialysis. It's not covered by the government insurance, and it's just too expensive. And then if you get a kidney transplant, they can't afford the immunosuppressive medications and the chronic medical monitoring. So for many children in many parts of the world, kidney failure is a death sentence. But if we could change kidney transplantation from being dependent on technology for a lifetime to being a one and done, where you could do the stem cell transplant and the kidney transplant, and then you need no medications, that's something which is achievable in many parts of the world because of the cost-benefit ratio and the fact that it would be much cheaper. What about other organs? We've seriously considered patients for a living donor liver like this. And as we get better at this, we may be able to do this with deceased donors. So maybe any transplant. So there's lots of options in the future. We're excited about where this is going to go. Um, there's still lots of research to be done, and we don't think that we have the perfect protocol, but this is research. So you go back to that guy in the mid 50s. He had an identical twin, and he was committed to do what it took to save his twin's life, and they were successful. And you look at the adults and the kids over the years who've participated in research. You know, back when I was training in the 80s, a kidney transplant has a 50-51 year chance of surviving because it was Imuran, was the immunosuppression. And then people participated in research for cyclosporin, people participated in research for tacrolimus, and every generation that participates in research improves the outcome for the future generation. And so, you know, I'm really passionate about this, and I think that we have a good option. But I've also been passionate about other things that it turned out didn't work out. So the only way to know is to do the research, be participating in clinical trials, and hopefully one day, this won't be what's going on. Right now, if your child is a kidney failure patient, once a kidney patient, always a kidney patient. They're either on dialysis or they got a kidney transplant, taking drugs, getting blood draws every month, seeing doctors, risks of graft failure, risks of complications, infection, cancer. We hope with this protocol to be one and done so we can stamp out the idea that once a kidney patient, always a kidney patient. For these kids that we've successfully gotten through the protocol, they don't think about having their kidney anymore. That scar is fading. They're on no drugs. The kidney's working. They don't have to worry about that kidney failing. So they aren't a kidney patient, really. They're just a kid. And that's what we hope for the future. I think I'm a couple minutes early. And Sarah, I'm done. So I'm going to stop my screen sharing and go back to you. And Sarah, you're muted.
This
Still
is
muted.
amazing.
Okay.
Is it working now?
Yep. Mm-hmm.
Sorry. This is so fascinating and really exciting to hear about. So thank you so much for sharing that. And we have quite a few questions that have been coming through. Some of them you've been answering as we've been going along. But let me start out with a question that is Does the parent or sibling donor have to be a 6/6 HLA match to do a stem cell transplant?
No, we're doing these on haplos, so a 3 out of 6. So your average run-of-the-mill mom or dad, and 50% of your siblings are haplos, and so that's where we've been focusing our focus on. The other research trials, like the adult Stanford trial and the one study and the Northwestern study, where they're looking at mixed chimerism, they need an immune system which is kind of raw and not really experienced, so they'll only take first kidneys. With our protocol, because we wanted to be able to um, treat the FSGS patients where they've already lost a kidney and they're the ones that are locked forever on dialysis. So our protocol allows you to have had a previous kidney transplant that had failed as well. So any old mom or dad or sibling.
Okay, great. Thank you for that. Here's a question. Doesn't a stem cell transplant wipe out all immunities? How long does it take to build them back?
Excellent question. Absolutely. And that's the goal. With the stem cell transplant, you want to like reboot the system, sort of like shutting off your computer and turning it on when it's doing things that you can't figure out. And so early on, um, we give the patients IVIG, and that replaces all the antibodies that they normally would be making. And then starting at about 9 months to a year after the stem cell transplant, we re-immunize. So all those baby immunizations, the DPTP, the MMR, the tetanus, all that stuff has to be re-immunized because your body's naive. And then when your body can show that it's making good antibodies, then we stop the IVIG. And then for things like funguses, we keep people on a low level of certain kinds of antibiotics and things like that. And you have to look out for yourself. Like there are certain things we don't want you to do. Like we don't want you to smoke marijuana. One of the highest doses of fungal spores is taking a puff of a joint because marijuana is grown in humid environments and the plants are loaded with fungal spores. And so there are certain things that we tell stem cell transplants not to do, and that's like top of the list. Another one is gathering eggs in a chicken coop. Bird poop is also a place that is loaded with fungal spores. And so we tell our stem cell transplants to stay away from that for years. So there are certain things that we have to be careful about. Absolutely. Yep.
Okay, that's all very interesting. Good to know. Let's see. How about, are kidneys the only organs that can use stem cells for transplantation?
So the nice thing about kidneys is it's relatively common to be a living donor for a kidney. So we can do the stem cell transplant and then take the same living donor 3 or 6 or 9 months later. Livers can also be transplanted from a living donor, and there are programs around the country that are working very hard to develop and optimize living liver donor programs. So this exact same technology could be applied in a situation where you had a living donor, it's hard to say, living liver donor. Hearts, obviously, there's only one heart, and so you can't be a living donor to that. But we're hoping that protocols will be developed over time that could potentially be used for deceased donors, but that's somewhere in the future.
Okay. And as a follow-up to that, there was a question earlier about, like kidneys, do living donor livers last
It's not
longer than,
easy.
yeah. Do they last longer than deceased donor livers?
I don't know. I think so, but I don't have the data on that.
Okay.
And if anyone else on the chat, any other transplant nurse or doc or physician or experienced parent wants to put something in the chat, that'd be great.
We're asking the nephrologist the liver question.
Right.
Let me see. Um, are there any options for children that are post-transplant to get them off immunosuppressants?
Mm. So, it's so hard because right now the standard of care is immunosuppression for a lifetime. Um, we don't know. Those studies have not been done. And the problem is to do research like that, you're basically taking a child who's stable and taking a gamble, stopping a drug. So over the years, there have been some nice studies in the kidney world about stopping prednisone. And a fair number, more than half the children can get away without prednisone and down to two agents. In the liver world, the liver is an organ which the immune system becomes tolerant to more easily than the kidney. It seems the small organs like the heart and the kidney, the immune system has a harder time developing tolerance, but the big organ like the liver, there's a lot of liver patients on one medicine. And so there's a difference between what kind of transplant you have and that potential. But right now, there's research on trying to get people off all immunosuppression, but it's very preliminary. And it's a risk because you're taking your child who might be doing really well, and you're taking a risk today for hopefully in the future being off immunosuppression, right? And that's hard. But there is research being done there.
Okay, great. Good answer. I think you answered this earlier, but I'll ask it again in case. Is this chimerism protocol you described being researched in other solid organ transplants also?
So in the adult world, it's really focusing on kidney, and in our world, it's focusing on kidney. But if we had a potential living liver donor, we would consider that in certain situations. We're still at the point where ethically, because regular organ transplantation works so well, to pick the Schimke's kids and the recurrent FSGS kids and the cystinosis kids, those are kids who, in addition to having kidney failure, have a major disease which can come back in the transplanted kidney or it can affect the rest of the body. And so ethically, we were in a position where it was ethical to try something totally new. But when you're just a regular old kidney transplant recipient, therapy is pretty darn good. So it's hard ethically until we really worked out a lot of the bugs in these kids who got multiple issues. But hopefully one day we'll be able to offer them to your run-of-the-mill child who needs a kidney transplant due to urinary tract infections or something like that in the future, maybe. Or maybe something even better will come along.
Okay, thank you. This is all incredibly great. I'm trying to see what other questions. There's one here. How do you find out about studies for pediatrics?
So asking your local transplant team, explaining that you're interested in participating in studies if there are any, because oftentimes the clinicians know about the studies. You can go to clinicaltrials.gov and plug in your disease and then see what's out there, because there are many clinical trials that I, as a kidney doctor in Southern California, I might not know about because they might be in Texas or Arizona or New Mexico. But going to clinicaltrials.gov and plugging in your disease, you can see what's out there and see if there's any potential clinical trials that in your situation you might participate in. Yeah.
That's great. Okay, clinicaltrials.gov.
.gov. Yeah.
Fantastic. Thanks for sharing that.
Mhm.
Wow, we have had a lot of great questions here, and this is so incredibly interesting to hear. We always appreciate you sharing the research that you're doing, and we always love having you on our conferences, Dr. Grimm. Thank you so much for sharing your time today. We really appreciate you.
I'm really happy to give presentations like this to people who are enthusiastic, and you're all, you know, tiger parents looking out for your kids. So I really feel that spending the time here is the best thing I could be doing. Yeah. Thank
Thank
you.
you. We agree, and we really appreciate it. So thank you so much. We really appreciate your time, and I want to invite everyone else to the final session today before networking, which is the Power of One: Redefining Advocacy and Policy to Help Transplant Children, and that starts at 4 p.m. Eastern. Thank you so much, Dr. Graham. We really appreciate it.